Okay, so today we're going to talk about the impact of cognitive and sensory impairment on the child. We're going with boring white for the PowerPoint. So cognitive impairment, here's your definition, is a general term that encompasses any type of mental difficulty or deficiency. So intellectual disability or cognitive impairment, you can use either term. When we're talking about cognitive impairments, most of the time these are diagnosed based off of experiences that the parents and the healthcare providers are having with the child. So delays that they're noticing in their development. Sometimes they can be diagnosed at birth. Those would be things such as Down syndrome or other genetic disabilities that are going to be evident either before or at birth. So when we're talking about an intellectual disability, we quantify that. So what we're looking at here is an IQ of 70 to 75 or even below that. To give you a little bit of a reference range, the normal IQ is 90 to 110. So when we're looking at the diagnosis, we're also wanting to diagnose these before the age of 18. And this is because if we don't notice it before 18, it probably has to do more with an injury that is causing this rather than the intellectual disability. In addition, once we're into that adulthood, it's going to be managed much differently. So you can see that the other diagnosis aspect has to do with the functional strengths and weaknesses. And here we can take a look at let me see if I can get this to go away. Go away. Well, the functional impairments. So here's what we're looking at. These are the adaptive skill areas that are going to be assessed to determine if there is some sort of cognitive impairment. So when we will use standardized tests. A lot of the time the IQ is a standardized test, and we're going to look at those results and compare them with the population as a whole. And then we're also going to be looking at the development of the child along the way and what developmental milestones are they making and what developmental milestones are they missing. So as you can see, we have 85% who are mildly impaired, and they have great success rates in education and being educated. And then there's 10% who are moderate, and they're trainable, but they're never going to reach that same level that the mildly impaired or those who have no impairment can reach. And the other 5% are severe, which we will address later. So as for the etiology, we're looking at the genetic, biochemical, and infectious, which those are going to relate to the severe category. And some things that we're going to think about here are going to be syphilis and rubella. And if you think back to those prenatal labs, or if you've had your OB rotation, remember those prenatal labs are always communicated. So we want to know if that mom is rubella non-immune. We want to know what her RPR, remember RPR, that's testing for syphilis. So some of those things are in those prenatal labs, because if mom is positive for syphilis, we're going to want to get her treated as soon as possible. Or if mom is rubella non-immune, we're going to advise her to be very conscientious of anybody with rubella symptoms. And we're also going to want to give her that vaccine as soon as she delivers. It's not something we're going to give her in pregnancy, but we will give her as soon as she delivers to protect those subsequent pregnancies. From the biochemical perspective, also the chemicals that are ingested. So we can think about, for instance, there was a drug that we used for nausea in England, I believe it was the 50s, and it caused major birth and cognitive defects. So there's different things that are going to affect that. Today, most likely what we're going to see from a biochemical perspective is fetal alcohol syndrome. From a genetic perspective, we're looking at, again, like that trisomy, or there's a few others that we'll discuss along the way. The other factors that the familial, social, environmental, and organic are going to be things that happen in the child's development. So how are we going to care for a child and their family when there is a cognitive impairment? First and foremost, as with a lot of this area, education. So early, we want to educate the family and ensure that there's early interventions. That's really key. So what we're going to be educating the family on is the milestones. And I go back to those pediatrician appointments. Those milestones are going to be documented, and they're going to be printed out on like after visit summaries and things, so that parents know what to look for and know what to report if there is a delay. We're going to, once we have identified a delay and identified an impairment, we're going to want to work on those self-care skills. Some of the severe range kids, we're not going to be able to teach self-care skills to, but the mild and the moderate, we definitely can. So we're going to, if you're involved in home care nursing, this would be the primary focus would be these self-care skills. So what does that look like? We're going to take a look at the child and see what they can do and what they can't do. We're going to watch them eat, for instance, or watch the parent feed the child. So we know what the child is capable of, and that way we can then make recommendations on how to further that child's capabilities. We're going to use, we want their optimal development. So every child is going to have a point to where they reach their optimal development, and that's what we want to guide them with. So we want to fix any physical defects that might be present surgically. So a lot of Down syndrome babies have cardiac defects. So they're going to go and they're going to have a surgery to fix that cardiac defect. Some of the other genetic predisposed kids have facial malformations, and so we're going to want to fix those facial malformations so that they can appropriately use their muscles in their mouth specifically for speaking and eating. So we're going to first fix any physical defects that we can. That's really going to help to promote that optimal development. And then we move on to play and exercise. So these children aren't going to play as effectively, but they still need that play and that exercise. So we really want to encourage parents, and if we're the caregiver, for instance, in the hospital, encourage them to expose these children to the sights and the sounds of play, and to give them as many playful sensations as possible, as appropriate for their developmental age at that time. We're going to utilize colors and songs as cues. So these kids need really concrete cues. So songs are really great for, let's say, how to eat, how to brush teeth. We're going to use colors as opposed to words for, say, stop or go. And those things will be able to translate much more effectively for that child. For communication, we are going to think about speech. So remember, speech requires both the receptive, so the hearing, and the expressive, so the ability to speak. So again, if we were able to fix some of the malformations on the face, then we're able to give that child the ability to communicate a little bit more effectively. So we can use speech therapy. If the child needs, is having a problem with the receptive aspect of it, then hearing aids. And we'll talk a lot more about hearing a little bit later. And then for those children who are nonverbal, then we want to figure out the best nonverbal way of communication. So there's a lot of computerized communication available now, but there's also sign language. There's something called bliss symbols, which is essentially little figurines and different symbols that signify simplistic communication. And so that works really well for some of these children. And then for discipline, so we definitely want to set limits for these children. We want to make sure that the parents are consistent and that all caregivers are consistent. They're not going to have the moral development that children without a cognitive impairment have. So we need to keep it with good and bad, positive and negative, because they're not going to be able to make those inferences for themselves. I think that's it for that slide. So this is a good visual of a child who is utilizing a communication device. You can see the colors, and you can also see the computer screen, probably from the 80s, but that's okay. This is going to demonstrate that the child is able to turn that screen on and off with the use of a button that they're able to communicate with. And the colors is obviously that concrete aspect that we were just talking about. So being able to point to colors as opposed to verbalizing, I want to spend more time on this. So pointing to a stop or a red color would signify I want to spend more time on this, is a much easier way to communicate. And here we have a child whose toy is placed just out of reach. So utilizing something that the child wants to be able to get them to proceed to that next step. And the child is going to move forward a little bit to get that toy. And then this is an example of a child playing. She's playing with a electronic dog, and she's able to push the button to make the dog kind of move and bark. And so it's an example of allowing a child with cognitive impairment to play at somewhat of a same level. And then this is play as well. We're utilizing a favorite toy for stimulation here. So some of the areas that we want to focus on, not only for ourselves in the hospital situation, but also, again, for the education of the parents, is encouraging that socialization. So it's important that these kids have similar opportunities to socialize with their peers. And it can be similar peers of cognitively impaired children and peers of similar age who are not cognitively impaired. There's programs that these kids can enroll in, and the parents can enroll them in early on. And we want them to understand the socially acceptable cues that they might be putting off, or in the unacceptable cues. So helping them to be more socially acceptable is going to promote that socialization in the end. Sexuality. So this can be a tough subject at any age to talk to a child about, but these children are not going to have the same sense of shame is not the word I'm looking for, but it's the only one coming to my mind. They're not going to stop themselves from exploring themselves sexually in a sexual manner in public quite as readily as a child without cognitive delays. So educating them in simplistic terms and telling them what they need to know. For instance, it's important for a girl of adolescence age to understand that she might be getting a period. She needs to understand what she should do about that and some basic hygiene. We're going to want to talk to them about appropriate sexual touching, inappropriate sexual touching, and how they can interact, and give them somebody to go to who is safe to talk to. Cognitively impaired children are frequently the victims of sexual assault because the perpetrator doesn't believe that they'll be able to adequately communicate what has happened. So we want to give them simplistic tools to utilize, but it's still very important to have those conversations. And when we're looking at future care, this is something we want to keep in mind for those families whose child isn't going to be able to live on their own. So the parents are obviously going to start to get older at some point to where they're not going to be able to care for this child. So what does that care look like after the parents are unable to provide that care or after the parents pass away? That's obviously a very sensitive subject, but it's important for them to consider and important for them to set up. Is the child going to go into residential care? Do we have another family member who's going to assume care? What's going to happen? And the thought of residential care might be really scary for those parents. During hospitalization, it's really important not to ignore these kids. Unfortunately, nurses are kind of scared of kids with cognitive impairments, mostly because as nurses, we're taught to treat the illness, right? And usually we have an end game and we're able to fix something. And this isn't really something we're able to fix. It's something that we need to be aware of and intervene with, and we need to address. So as a nurse, please don't be that nurse who ignores your cognitively impaired patient, whether it's a child or an adult. We want to interact with them, provide them play. We want to make sure they're not isolated. And we need to address what their abilities and inabilities are. And so that's kind of an interesting aspect of how do we bring that up with the parents? Do we want to say, so is your child potty trained? Probably not, because that's more of a negative connotation that it's something that they should have done. What we're going to try to do instead is say, tell me about your child's toileting habits. And then end it always with, is there anything else I should know about your child? I think that's a general assessment skill. Is there anything else you think I should know? Because you might not have asked a specific question, and so they might not think it's important because you didn't ask it, even though they're thinking about it, and they might just think, oh, well, she doesn't care about that, or he didn't ask that, so that's not a specific question they need answered. So always end your assessments with, is there anything else you think I should know to make sure we provide the best and safest care? And people come up with the craziest things. They're like, oh my gosh, when I asked if you had a problem, why didn't you say that in the first place? So I always end my assessments with that question, and you'll be surprised at the answers that you get. So just being very cognizant of the way we're communicating with the parents and the way we're asking about those child's abilities, and present them as abilities as opposed to disabilities. And then how can we prevent cognitive impairment? Is it preventable? There's certain cases where it's not preventable with the genetics. However, almost all of those other factors are modifiable risk factors, right? So syphilis and rubella, we need to screen our patients prenatally. Biochemical, we need to educate about fetal alcohol syndrome and the effects that alcohol can have on those babies. Family, so we might get a cognitively impaired child because they were a shaken baby. So education around how to adequately cope with a crying child and to never sit there and actually shake them, because those poor little babies will never be the same, unfortunately. And we want to give just specific information to the parents so that they can translate that into what they need to do to hopefully prevent some of these impairments. This is a child who has a cognitive impairment, but is able to move. She has mobility due to her chair and a communication device. So we do have some great technological advances that have really helped these children and into adulthood have more control over their lives. So Down syndrome is one of our genetic components, and it's, as you can see, the statistics here, and we actually don't know the specific cause. And what I found is interesting is that not all of it is the extra chromosome, the extra 21. So there's a few other things here. And you can see here there's the maternal age and the risk factors. However, saying this, your risk does increase at age 35 and goes up even more by age 40. However, 80% of Down syndrome babies are born to women under the age of 35. Now, that's mostly because women under the age of 35 are having more babies than those over 35, but it is an interesting way to look at it. So you can see here the clinical manifestations, and one of the things that we're going to look for on that newborn assessment that we're doing is the simian crease. So when the child has just one crease on their hand, that's an indication. We're going to look for the ears, the level of the ears in conjoinance with the eyes, and we're going to look for potential web neck. So all of those things would be physical signs that this baby might be Down syndrome. Now, with the testing that we do prenatally, the majority of cases we would know ahead of time, but some parents do decline that testing just fine, so they might not know before. We're going to diagnose it though with the chromosome analysis. It's going to be kind of our final diagnosis. And I talked about this a little bit earlier, but you can see from the problems here that the congenital heart disease, these kids are at risk of hypothyroidism, and they're actually at a higher risk of leukemia as well. So this is just a picture of a little girl. She's about 2 who has Down syndrome. So you can see some of those characteristics that were described above. Another characteristic is going to be kind of a protruding tongue. Their tongue seems large for their mouth. So what can we do for therapeutic management? We're not going to cure the Down syndrome as it's a chromosomal abnormality. However, we can fix a lot of the congenital abnormalities. So the heart disease, if they have hearing issues or issues with vision, then there's some things that we can do about that. We're going to screen their thyroid and do more frequent blood tests to screen for leukemia as well. So the prognosis is that these Down syndrome kids are living to be a little like 60 and older now. So their prognosis is really good, and they have a great quality of life. Most Down syndrome kids report being happier than the average adult. So that's probably a really good thing, because as our society continues, adults get more and more stressed out, and these Down syndrome kids are just loving life. So that's great. And they can do so much. There's very few things that they can't do. And most Down syndrome kids can end up living on their own with some support systems in place, which is great. We want to support the family at the time of diagnosis. It might be early on in pregnancy. It might be at delivery. So being open to that support is really great. Providing support groups is a good way to help that family cope with that information and help them to transition into what that means to have a child with Down syndrome. We want to give them the systems that they're going to need. So whether that is at that prenatal appointment or whether it's at birth, we want to provide them with as much information as we can. The prevention of physical problems is again along the lines of fixing those congenital problems that might be there, screening for the hypothyroidism and the leukemia. And then in addition, we want to educate the parents on the actual physical characteristics of the Down syndrome baby. So these kids are a little bit more flaccid. They don't have the muscle tone that kids without Down syndrome have. So they might not cuddle into the mom or the dad, which when we're looking at attachment, parents might think that this baby isn't attached to them and isn't comforted by them because they're not cuddling into them. So we want to make the parent aware that this has nothing to do with them. It's just that this baby doesn't have the the muscular control to actually do that. We also want to make sure this kid ends up swaddled as a newborn, because their joints are very bendable and movable. They're at risk for physical injury, musculoskeletal injury, because they're a little bit more flaccid than the normal child. They have an increased risk of upper respiratory infections because of their muscles of respiration aren't fully developed. Because of the structure of their nasal passages, that also increases the risk of upper respiratory infections. So we want to make sure that these parents understand they need to keep the nose clear and the mouth clear, because if stuff stays in there, then that increases that risk of infection. And feeding can also be slightly challenging, especially for the younger Down syndrome kid and baby, again, because of those same things, that underdeveloped musculature that doesn't have quite as much strength. So Fragile X syndrome is the second most common cause of cognitive impairment. And this one is kind of interesting. You can see it's definitely not as common as Down syndrome, and it's caused by an abnormal gene on the X chromosome. So although boys and girls are both at risk, boys are a little bit more at risk. Here are the clinical manifestations of the Fragile X syndrome, and they're going to have a very specific look to them as well. So some of the behavioral features is what I think makes this an interesting syndrome. As you can see, there's the cognitive impairment, delayed speech and language, and then we have the hyperactivity, autistic-like behaviors, aggressive behaviors, and then the hypersensitivities. So when you're thinking of this, it really does sound like some of our autistic kids that we're seeing a lot of now, right? So there's a lot of treatments that can really help these Fragile X syndrome kids. We can give them medication for behavioral control, for the hyperactivity, and the referrals to the early intervention programs are going to be key, because those are going to help them to develop those skills that they need to be able to overcome that significant aggression that they're going to have, and some of those autistic-like behaviors. So the prognosis for the Fragile X syndrome kids is a little bit better than the Down syndrome, depending on medication and intervention. For hearing impairment, this can be any child, but it falls under the sensory impairment aspect. So we're not talking cognitive impairment anymore, but the sensory impairment with the hearing. And you can see the statistics here, and it can be common among infants to identify and among children. And there's a variety of different reasons why there could be hearing impairment. So anatomic malformation, so just that the ear is not formed appropriately. And then we're going to look at family history, so it might be a genetic thing. And then you can see that a lot of the rest of them are all have to do, with the exception of chronic ear infections, but most of them have to do with pregnancy-related issues. So low birth weight is going to be an impact of the pregnancy. The ototoxic drugs like oxygen is going to be an impact of the delivery. The perinatal asphyxia, and perinatal infections are both going to have to do with the labor and the delivery, and something infection-wise, this can impact the baby as early as an infection early on in pregnancy at like 6 to 8 weeks. This can have an impact on that baby. And cerebral palsy. And cerebral palsy is considered a birth injury as well. So a lot of these have to do with the appropriate management in the labor and delivery setting and making sure that these babies have the adequate oxygenation while mom's laboring. And then remember, when a baby's being resuscitated, we've talked about this, how we don't resuscitate with oxygen initially, right? We resuscitate with pressure to open those lungs at 21%. And this is one of the reasons. And when we talk about vision, it's the same thing. That O2, the extra O2, can cause hearing loss and vision loss. So that resuscitation effort is really important to keep it at that 21%, unless otherwise indicated, which there's definitely indications there. So we have cognitive hearing loss, and we have sensorineural hearing loss, and then we have the mixed. So cognitive hearing loss is the most common, and it has to do with the transmission of the sound. It also it has to do with how loud things are. So with cognitive hearing loss, we can utilize hearing aids because the hearing aid is going to amplify that sound. So sensorineural has to do with damage to the nerves. That's going to be a little bit different. And that can happen congenitally, or it can be some sort of an exposure issue. The mixed actually usually happens from frequent middle ear infections. It can also have to do with the middle ear infections damage both the conductive aspect and can damage the nerve. So if we're having frequent ear infections, then the child needs to be seen and treated and figured out why those ear infections are happening. And then we might use tubes to prevent those frequent ear infections so that we can prevent that mixed hearing loss. For the central auditory interception hearing loss aspect, we have organic, which is going to be a lesion of sorts. So it's it's a lesion in the brain that is going to cause aphasia or agnosia. So it has to do with the processing of the speech. So either they can't process it in or they can't process it out. And that has more to do with like a lesion in the brain. And then functional is going to be where there's no lesion present. And this has to do, there's conversion hysteria, infantile autism, and childhood schizophrenia. So this, again, it relates more to the function of what process they have going on in the background. And that is brain related, but it's not a lesion specific. So how do we measure hearing impairment? And I know I mentioned in class that, we want to be careful with those decibels because anything over 80 decibels can cause hearing damage. If you take a look at table 37.1 and 37.2, it'll give you some really good specifics for the decibels and the frequencies and how it can, where we see hearing loss and what hearing loss is considered. So take a look at those numbers in your book. So what are we going to do for these hearing losses? Well, we already kind of talked about this from a conductive hearing loss perspective. We're going to fit the child for hearing aids. And the other thing that we might want to look at real quick is wax. Is there waxy buildup in the ear that's causing that hearing loss? So typically if they're going to a specialist, they've already gone past that point of having the waxy buildup, but the wax will prevent the conduction of the sound through the ear canal to appropriately activate the hairs and all that fun jazz. So we're going to fix the problem. So if it's wax, we're going to remove it. If it's something else, hearing aids work great because they amplify the sound. Now, if it's a sensorineural hearing loss, I'm sorry, I'm having difficulty with that word, but you know what I'm saying. We're going to look at cochlear implants, and the earlier we can get those, the better. So you've probably noticed that the babies all in the hospital, the newborns all do a newborn hearing screen. And this is why, because the earlier we can identify these issues, the better we can fix them, and the better we can intervene and provide better outcomes for these kids. So you can see, this is a little girl. She has an eye patch, and she has some hearing aids in. So we really want to identify the hearing loss as early as possible, especially if it is something that is present at birth, then we can intervene that much sooner. If it's not identified in that initial hearing test, hearing screen that's done as newborns, then there's multiple places across the lifespan of the child before they get to school where hearing tests are done. I think they start them at 4. So it would potentially be identified then. If not, it's almost always identified in school because of learning problems. So sometimes the child's having a tough time hearing and they act out in school and have behavioral problems, or having a problem with reading or with writing and following instructions. And one of the first things that's done when a individualized learning plan for the child, or individualized education plan, IEP, is developed for a child is a hearing and a vision test to rule out any causes because of hearing and vision. So here are some things that we can look for in the infant, and we can tell parents that to look for that we might suspect hearing loss is that lack of the startle reflex, so that moral reflex. If they don't have that, there might be some hearing loss, and obviously lack of any reaction to auditory stimulants. So if the mom is saying the baby's name, the baby should really turn towards the mom's voice. If we're not seeing that, then there's probably some hearing loss there. And you can see some of the other manifestations that are present. If you look at box 37.4, go here, it gives you a lot more information on some of these manifestations. So the profound deafness is likely to be diagnosed in infancy, mostly because we do that hearing screen. And when we see abnormalities in speech development, and I kind of mentioned this stuff earlier, and learning disabilities, we're going to look for those hearing and those visual problems first. So some of the resources that we have for kids who have hearing loss, and some things that they can learn and ways to communicate for them are listed here. So from a lip reading perspective, some kids can learn lip reading pretty well. The thing with lip reading is that only 40% of the spoken language is understood with lip reading. So sometimes lip reading and cued speech can be combined. So it's lip reading and some hand cues. And then we have the sign language, which we're all very familiar with. So the children who are profoundly deaf are going to learn sign language. And then we have a lot of aids that we can utilize. So you've probably noticed your iPhone has a big flashing bright light as a designation that something's coming through to the phone. So that is a perfect example of care management for the hearing impaired. So that gives them a visual cue as opposed to just the ding that something is going on. Speech language therapy, we really want the parents involved in this. So that's going to be an important role of the nurse, is to encourage the parent involvement, because obviously we want the parents to be able to communicate with their child, whatever it is. Closed captioning, special phones that type it out as opposed to speaking on the phone. We have adaptive classrooms. So if they're profoundly deaf, there might be a special school that is utilized. But if they have hearing aids, then having a classroom, for instance, my 5th grader is in a class with somebody who's hearing impaired, and they carpeted the rooms. The room's not typically carpeted, but they carpeted the room to help with the sound bouncing off that tile floor, linoleum, whatever the type of floor is. So providing an environment to decrease the background noise, and then keeping that class noise level down. Good luck, right? But still having the children be aware that she needs to, for her to hear effectively, you got to stay quiet. So encouraging that. And it's been a really positive environment for this little girl, so it's great. So during hospitalization, so an interesting thing about the hearing impaired is that the hospital is required to provide an in-person sign language interpreter. So hospitals have a line that we can call and bring in that interpreter. These patients know their rights. They know them very well. So they will ask for one. Now we also have the iPads where somebody can be on. So in the meantime of getting the interpreter there, we're still able to communicate. And typically whoever is with them is typically hearing and able to communicate as well. But it is required for the hospital to provide a sign language interpreter for the hearing impaired. You can see here some other common ways that we can communicate with the hearing impaired during the hospitalization. So when we're looking to prevent hearing impairment, we talked a little about this earlier, but we're going to be very cognizant of those recurring ear infections, because the child who has those recurring ear infections is at an increased risk. And when we talked about the risks here, we have what we're going to do to prevent it. So we're going to avoid those ototoxic drugs. We're going to, again, we're looking at the syphilis and the rubella. Blood incompatibility can also cause that, and that's that RH, the RH negative versus RH positive for mom. And then for kids, we want it, exposure to noise pollution is huge. So again, that table in your book tells you like what an airplane taking off is at, which is interesting. So we want to make sure our kids are aware of their ears and their TV volume isn't too high. We want to educate parents to get specialized headphones that can't go above a certain decibel so that the kids can't be cranking that music all the way up. And this is going to be especially important for adolescents, the communication there, because they're the ones who are going to want those loud headphones on and to drown out everybody else. So making sure they understand that too loud is going to impact their hearing down the road. So when we're looking at visual impairment, we can look at a couple different levels. So we're looking at the partially sighted and the legally blind. So partially sighted are, like it says here, educated in the public school. Legally blind or not. And legally blind is not a legal term. I'm sorry, it's not a medical term, it's a legal term. So it's very clear, it's legally blind, and it is a legal term. It is not a medical diagnosis. So again, we're looking at those prenatal, those postnatal infections, the rubella, the syphilis, the reason why we put the erythromycin in the eyes, the chlamydia, the gonorrhea. All of those things can lead to visual impairments in these children. The retinopathy of prematurity, so the little babies who are born super premature are at risk of retinopathy, which can lead to blindness. Trauma, so stick in eye. We always tell kids not to run with a sucker in their mouth so that doesn't gag them. They should be running with a pencil in their hand, a stick in their hand, nothing like that, because they fall down, goes in the eye, that eye's done, right? So again, education around just safe practices. And then you can see some of the other disorders that can be associated with visual impairment. So when we're looking at the different types of visual impairment, we want to look at where the light falls in relation to the retina. So with myopia, which is nearsightedness, it's going to fall in front of the retina. With hyperopia, which is farsightedness, it's going to fall behind the retina. And then the strabismus might be, that's more of a cross-eyed, and the amblyopia is the lazy eye. And those may or may not be refractive related to whether the impairment is caused by that, the light falling in front of or behind the retina. It might just be the acuity of where the eyes focus. So again, we talked about trauma. We want to keep these kids really aware that running with something or falling on something. So just aware of their environment. We want to try to prevent injuries as much as possible, as much as you possibly can with a child. Here you can see the various infections that might cause some sort of visual impairment. These could be the conjunctivitis could be temporary, and it could cause permanent damage. So we want to treat as soon as possible so that we don't have the damage that if we let things go. So what are we going to do with our visually impaired kids? And we're going to look for those who are at risk, and really, again, educate the parents, educate the children, and then we're going to look for behaviors that indicate the vision loss. We're going to screen kids for visual acuity, and we're going to be very cognizant of those kids whose pupils don't react to light. So that's an indication that there is some sort of vision loss. So for the kids who are visually impaired, we're going to want to promote the parent-child attachment. So a lot of that initial attachment, especially from that infant, remember that infant can see from the mom's boob to the mom's face. So that visualization isn't present for that baby. So having that and knowing that is important. Sorry, slight disruption. But we were talking about the parent-child attachment, and it has to do with if the child can't see the parent, there's going to be a perceived lack of bonding by the parent. So again, just educating the parent. Just because your child isn't visually responding to you doesn't mean that they are not bonding with you, because there's so many other aspects that allow for the bonding. And the optimal development, it's going to be around referrals. So we want to provide as many referrals as necessary for the degree of severity of visual impairment for the child, so that they're able to establish various programs and whatnot to educate the child so that they can reach that independence, which is the goal, is the child to be able to become independent as an adult, which leads into the next one. So there is going to be a delay in development with, for instance, with play and socialization. Children learn by watching. And so with the visually impaired child, we're going to have to teach them differently, because they're not going to be able to watch. So for instance, remember those toddlers imitating the adult. The visually impaired kid isn't going to be able to imitate the adult because they're not able to visually see what the adult is doing. So we're going to have to physically walk them through some of those movements so that they're able to experience it in a different way. So it's good. There probably will be a slight delay, but that's expected, and it does not mean cognitive impairment. It's just that so much of the world is interpreted visually that there's a delay in development when that interpretation isn't available. These children are able to learn via Braille, via audiobooks, and other audio learning materials. So there is a lot available for the visually impaired, and they are more likely than not able to achieve complete independence with the assistance of some really good devices. For the hospitalized child, we're going to be really concerned about their environment. So visually impaired children learn their environment, and they learn what it means to have or they learn their environment by knowing where everything is, and they're safe in their environment because they know where things are. A hospital is a foreign environment to them, so we're going to have to give them a really good orientation to where they are, in addition to during the treatments, provide them with a step-by-step audio explanation of what's going on and reassurance. We've talked a lot about this. It's very similar to hearing. So again, we're looking at that rubella, the syphilis, those, the drugs that can be toxic, like the oxygen, the premature babies, things like that. So we know that there's various diseases that can cause blindness, and then helping with the safety. Again, we've talked about the trauma, so making sure that we're educating parents around those safety items that might potentially cause a trauma to the eye. As for those who are both hearing and visually impaired, it is obviously going to have profound effects on development, as we're having to learn different ways, and not everything is learnable for the hearing and the visually impaired. The outcomes for this population is very unpredictable. So it's going to have to do with their temperament, which is going to give them either they're going to want to learn, they're going to be frustrated, they're going to easily learn, or going to be challenging to learn. It's going to have to do with their cognition. It's going to have to do with their teachers. There's going to be a lot of factors that contribute to the success of the goals for these children. Total independence is the goal, as with any impairment. However, it's not realistic for everybody in this population. If finger spelling has to do with spelling the word, so you would spell the word on the patient's hand, is what finger spelling refers to. So when we're looking at children who are have communication impairment, one of the top reasons for communication impairment now is autism. And as you all know, we don't know what causes autism. There was the one study that linked autism to the MMR vaccine, and that study has since been revoked by the individual who did the study, saying it was a poorly done study, and there has been no study that's been able to replicate that result. However, a lot of parents are very nervous about vaccines, and we want to address that and not just dismiss it, because dismissing it is not the way to educate people. But regardless, talking more about the communication impairment, we're going to look for the social interactions. This is something that is diagnosed a little bit later, and it's becoming very common. So 1 in 68 children have some sort of autism spectrum disorder. It's 4 times more likely to occur in boys than in girls. From the neurological development aspect, so some of the things that are signs is that there's a delay in hand dominance. So determining which hand the child is going to write with is slightly delayed. And there's a persistence of the primitive reflexes early on. So that's a sign earlier in infancy. If some of those primitive reflexes stick around a little bit later, then that's a sign that this child might end up falling on the spectrum somewhere. So it can be improved or overcome. And with incredible cognitive behavioral therapy, some of the autistic children are able to overcome almost all of their difficulties with it, especially with the communication aspects of it. So early intervention, early therapy is going to have drastic benefits on these children. I think we're all fairly familiar with autism, but it is a disorder that affects the communication and the ability to bond with other people. So there's difficulty with eye contact, difficulty with body contact. There's going to be a language delay in these children. There's difficulty with just communication as a whole, because the way their communication, the way their brain processes, especially that nonverbal communication, is much different. And although they might be able to take what's being said, what they're reporting out verbally and non-verbally is going to be challenging and much different from how somebody who's not on the spectrum processes that information. It can be severely disabling depending on the severity of the spectrum. There are autistic children who are nonverbal, and those children are not going to be able to completely overcome their challenges. But again, that early intervention is going to have a drastic effect in a beneficial way for these children. There is no cure, but there are a lot of therapies that we can do to help them overcome some of the challenges and some of the ways that they process information and make it a little bit more acceptable and a little bit more along the lines of what society expects from communication. So what does it mean to be a family disease? It's not saying that everybody in the family has the disease, but that the disease affects the entire family. So often a family who has a child with autism is going to have limits of what they can and cannot do as a family as a whole. They're going to have a different family structure in the home. They're going to have different rules in place and different sets of behavioral modification aspects associated with what they do in everyday life. And they're going to be communicating differently as a family. So it affects the whole entire family. And a lot of the time, parents have a lot of guilt or shame. So we really need to encourage those parents. We also need to really let them know that the way their child is behaving is not a result of anything they did, but it's just that their child's brain is processing information a little bit different, and therefore the output of information is a little bit different. We want to get these people and these families in support sorry, I lost my train of thought. Support groups is what I was trying to say. So we want to provide them with information about support groups and family counseling, because establishing that family dynamic is going to be key to success with that autistic child. So here's a great question to end our lecture on. I know it was kind of a long one, I'm sorry. But the nurse is discussing sexuality with the parents of an adolescent girl with moderate cognitive impairment. What should the nurse consider when dealing with this issue? So A is not correct. We're not going to recommend sterilization. The sex drive is not limited in these individuals, and sexual intercourse occurs quite frequently. And I did mention that that cognitively impaired individuals are frequently the victims of sexual abuse as well. So our correct answer is going to be C. Individuals with cognitive impairment need a well-defined concrete code of sexual conduct. And that kind of goes with everything for the cognitive impairment. We really want to give them concrete information. So I hope you enjoyed, and I will see you soon.